Hey everyone, today we're going to tackle something every pathology trainee runs into sooner or later, the unexpected find in a totally routine appendix. We're going to break down the College of American Pathologists, or CAP, protocol for appendiceal neuroendocrine tumors. So if you're a trainee, this is definitely for you. Let's make this dense protocol make sense.
Okay, so picture this. A routine appendectomy for acute appendicitis lands on your bench. You start slicing into it, and there, right at the tip, you find a small, firm, kind of rubbery yellow nodule. And just like that, your day got a lot more interesting. This is the classic way we find an appendiceal neuroendocrine tumor, an incidental finding that changes everything.
So, when you find one of these, what's your first move? You grab the CAP protocol. And look, this isn't just some boring checklist. This thing is the gold standard. It's how we make sure our pathology reports are complete, accurate, and that everyone speaks the same language. Following this protocol means that every clinician, anywhere, gets the exact info they need to make the best call for the patient.
So, we're going to follow this specimen's journey from the moment we find it. First up, we'll make sure we know exactly what it is. Then, we'll get up close and personal. We're talking size and grade. After that, we put on our detective hats to figure out how far it's spread and check those all-important surgical margins. And finally, we'll put all the clues together to nail down the final stage. All right, first things first, and this is probably the most critical step of all, making sure we're using the right tool for the job. You know, the world of appendiceal tumors is pretty diverse, and if you grab the wrong protocol, well, you could make some serious mistakes in staging that have real consequences for the patient's treatment.
So, what are we talking about here? This specific protocol is only for well-differentiated neuroendocrine tumors, or NETs. You might still hear people calling them carcinoid tumors. That's the old name. Now, if you're looking at a poorly differentiated neuroendocrine carcinoma or a goblet cell adenocarcinoma, you gotta stop. Seriously, put this protocol down and go grab the general appendix carcinoma protocol. They're totally different roadmaps.
Okay, so we've confirmed we have a well-differentiated NET. Perfect. Now we can zoom in on the two factors that are going to drive almost every clinical decision from here on out: the tumor's size and its histologic grade.
Now here's something that's a little counterintuitive, right? In most GI cancers, we're obsessed with how deep the tumor has invaded, the T stage. But for appendiceal NETs, size is king. Seriously, the entire staging system is built around it. That means getting a super accurate measurement is absolutely positively crucial. And here is the magic number you have to remember: 2 centimeters. A tumor bigger than 2.0 centimeters often means that patient needs to go back for a second, bigger surgery, a right hemicolectomy, to check the nearby lymph nodes. If it's smaller, that first appendectomy might be all they need. So yeah, your measurement on the gross bench directly impacts the patient's next surgical step.
Next up is the grade. I like to think of this as the tumor speedometer. It's not about how weird the cells look. It's all about how fast they're dividing. And we figure this out in 2 ways. Either we manually count the dividing cells, that's the mitotic rate, or we use a special stain, key 67, to see what percentage of cells are actively multiplying.
Let's look at how this plays out with the official WHO grading. This table right here is your cheat sheet. The cutoffs are crystal clear. A G1 tumor is your slow and steady type, very few dividing cells. G2 is in the middle of the pack. And G3, well, that one's living life in the fast lane. Oh, and here's a pro tip. If your mitotic count gives you 1 grade and the K67 gives you another, you always go with the higher grade.
Counting mitoses can seem a bit intimidating, but it's really just a systematic process. First, you scan the whole tumor on low power to find the hot spot, the area that looks the busiest. Then you zoom in and you meticulously count every mitotic figure you see in a specific area. Finally, you do a little math to get that count into the standard units of mitoses per 2 square millimeters, and that number gives you your grade.
Okay, so we know the tumor's size and we know its speed, but where has it gone? It's time to map out its local spread.
The CAP protocol basically gives us a checklist to follow here. We need to systematically document the deepest point of invasion. We start from the inside layers, we move out through the muscular wall, and then into the fatty tissue around the appendix. Has it broken through the surface? Is it stuck to another organ? Every layer it crosses is another critical piece of the staging puzzle.
While you're looking at how far the tumor has gone, you need to have your eyes peeled for something really important: tumor cells sneaking into tiny lymphatic channels or blood vessels. Finding any lymphovascular invasion is a major red flag. It means the tumor has figured out how to use the body's highways, and there's a much higher risk it's already spread to lymph nodes. And here's another really key detail, straight from the protocol's notes. Even if you don't see clear-cut lymphovascular invasion, just the presence of tumor in the mesoappendex, that's the fatty tissue that holds the appendix's blood supply, that fact alone is a powerful predictor that it's probably in the lymph nodes. You have to mention that clearly in your report. Now we get to one of the most important questions we answer for the surgeon. Did you get it all? Our report on the margin status is exactly how we tell them if that first operation was a success. To really get a handle on margins, let's check out this diagram from the protocol. It's an awesome visual. It shows all the different surfaces a surgeon creates when they take out a piece of bowel, and it tells us which ones we have to ink and check as a margin.
Let's break this down. So think of the appendix as a tube. In diagram A, that tube is completely wrapped in a thin, slippery layer called the peritoneum. The mesenteric margin is where the surgeon cuts the blood supply away. But in B and C, part of the tube isn't covered by peritoneum. That raw, dissected surface, that's the radial margin, and we have to check it carefully.
The good news is, for a standard run-of-the-mill appendectomy, it's pretty simple. You've really only got two main margins to worry about. The proximal margin, which is the staple line where the appendix was cut off from the cecum, and the mesoappendical margin, where they divided that fatty tissue. So, we've gathered all our evidence, the size, the grade, the invasion, the margins, all of it. Now, it's time for the grand finale. We're going to synthesize all of this information into the final pathologic TNM stage. So the T in TNM stands for tumor, and it's a direct summary of the primary tumor itself. And as we've already hammered home for these appendiceal nets, it's a combination of two things, the tumor's biggest dimension and its depth of invasion. And here's how it all comes together in a nutshell. A tumor that's 2 centimeters or less, that's a PT1. If it's bigger than 4 centimeters, or if it's already invading the mesoappendex, it automatically jumps to at least a P3. And a PT4? That's a tumor that's busted through the surface or is physically stuck to another organ. See, it's just a logical progression based on all the data you've carefully collected.
The N for nodes is way more straightforward, thankfully. If the surgeon took out regional lymph nodes for you to look at, it's a simple yes or no question. Are they positive for tumor? That's PN1. Are they all clean? That's PN0. Easy as that.
And there you have it. The report you finally sign out, built on the rock-solid foundation of this protocol, becomes the roadmap for that patient's entire treatment course. It's a huge responsibility. But it also makes you think, right? As we learn more and more about the genetics and molecules driving these tumors, how will these classifications change to become even smarter and more precise? It's just a powerful reminder that our work is always right at the cutting edge of medicine. Thanks for tuning in.